The Community Memorial Health System Fall 2021 Speaker Series Online is brought to you by Mission Home Health. Mission Home Health and Hospice is committed to taking care of people by providing the highest quality, cost-effective care wherever the patient calls home. With over 14 locations, Mission delivers skilled home health, hospice, and palliative care services to more than 3,000 patients a day. As a preferred partner with several health systems, Mission works with providers to customize each partnership to provide exceptional coordinated care. Visit our website to learn more at www.homewithmission.com.
Good evening, and welcome to the Community Memorial Health System Speaker Series Online. My name is Brianna Callis, and I'm excited to be joining you tonight for what we hope will be an engaging and thoughtful conversation on opioid addiction, the forgotten epidemic. I am joined tonight by Community Memorial Health System Addiction Medicine Specialist, Dr. Chris Kerrigan. Thank you for being here, Dr. Kerrigan.
Thank you.
In just a second, I'm going to give you a chance to tell our audience at home a little bit about yourself and how you ended up in Ventura at Community Memorial Health System. But first, I just want to address a couple of housekeeping items for our audience at home. This is a little bit of a new format for our speaker series online. And so I really want to encourage everyone to use the question and answer feature on Zoom.
Just submit your questions throughout the presentation. We'll be pausing throughout to answer your questions. And so we'd love to have those submitted as we go. Dr. Kerrigan, tell us a little bit about yourself, where you're from, your backgrounds, a little bit of your education history.
Sure. So I was born in Los Angeles and moved to Massachusetts when I was 3 years old. Raised in Massachusetts and Colorado. Went to medical school in Europe and residency in internal medicine at the Billings Clinic in Billings, Montana. Fellowship at Vanderbilt University Medical Center in Nashville, Tennessee. And then finally back to Southern California, where it all started. I'm happy to be here.
What do you like most about Ventura?
The climate and the beach. I'm an avid beach goer, and I don't like cold and snow, so it's a great place to be.
Well, we have these 80-degree October days for your beach, so it's great to have you here. We're really lucky at the Community Memorial Health System to have Dr. Kerrigan here practicing addiction medicine. We have a lot to cover tonight. This is a really big topic, and I think we're just going to dive right in. So I think a lot of our audience at home is probably familiar with the terminology, the opioid crisis or the opioid epidemic. So why don't we talk a little bit about the history, though? Because, you know, before you and I had a chance to talk, I didn't know that this isn't our first opioid epidemic. So where did this all really begin?
Yeah, for sure. So opioids have been around a long time, and as long as we've had opiates, we've had opioid use disorder, and people have struggled with getting off of them. We have waxed and waned various opioid crises in this country. The first major one that's well documented would actually be after the Civil War, when 400,000 Civil War veterans suffered from opioid use disorder, really heavy amounts of morphine that were being prescribed for pain control. Looking back at it, they were probably self-medicating for PTSD and developing opioid use disorder. But we've gone up and down a number of times. It's very multifactorial, what causes epidemics and opioid use to go up and down, and we waxed and waned.
Yeah, I think you mentioned at one point that there were a few other times throughout our history as a country that we've seen a rise in opioid use disorder. So let's talk about present day. I think that in 2019, there was a pretty significant spike in opioid use disorder and opioid overdose-related deaths. But I think in 2020, we saw a pretty significant increase too. So what does it look like today?
Yeah, so nationwide, over 93,000 people died of overdose in this country. It's the leading cause of death of people under the age of 50. Nationwide, we had a substantial increase in 2020, and unfortunately in Ventura County, we increased even higher than compared to the rest of the nation. We had a 45% increase in overdose deaths in this county last year.
Which is significant.
Yeah,
I did want to point out, you have a graphic up on the screen that just kind of shows the rise in opioid-related deaths over the last kind of 20 years or so, and you do see there at the end in 2019 that significant number. I also read that in 2019, 70% of all drug-related overdose deaths were opioid-specific. So let's dive into a little bit more data about opioids specifically. So you mentioned 23 million Americans have a substance use disorder.
Yep.
Tell us a little bit more.
Yeah. So CDC estimates 23 million Americans have a substance use disorder, yet unfortunately only 10% receive treatment annually. I think we're in a particularly harmful epidemic right now because we've actually learned this was particularly bad, but we also have far better treatment than we ever have before. And it's unfortunate that so few people end up getting treatment for it. 22% of hospitalized patients have an active drug or alcohol use disorder. Yeah.
So what do you think is the cause of such a low percentage of people with opioid use disorder seeking or receiving treatment? Is there a stigma attached to addiction, and is that like playing a role in the low numbers of people receiving treatment?
Yep, that's exactly what causes a low number of people to get treatment. There's a massive stigma both by the general public and unfortunately in the medical community. It's something that most physicians like myself who receive advanced training in addiction don't even fully realize until they get the training that you see just how bad the stigma is. Because we're generally not trained to treat this in medical school or in most residency programs like we already treat other general diseases. Yet treatment is really the way most people get better.
So how do you go about assessing and diagnosing a substance use or opioid use disorder?
So like my clinic, although I do addiction medicine, I'm a general internist. And I diagnose it like I would any other disease. We have diagnostic criteria for all other diseases. If somebody has a substance use disorder, they'll meet a very specific set of standards that I'll make that diagnosis. Or if they're using illicit opioids or other drugs in order to treat an underlying condition, I'll diagnose that condition and I will treat that condition. And that can be nuanced, but it's important to do what's right for that particular patient.
So when it comes to assessing and or diagnosing, you really approach it like you would any other disease.
Yeah, correct. And, treatment of substance use disorder is a combination of lifestyle changes and medications and treating, other comorbid conditions very similar to hypertension or diabetes. The three major pillars for treatment of substance use disorder would be, one, the treatment of cravings, which we have very excellent medications to do now. Diagnosis of any underlying conditions which can be triggering or lead to substance use. There are very few conditions or diagnoses in medicine that you can't get some sort of temporary relief from with either stimulants, alcohol, or opioids. Those are rarely long-term treatments that give you any gain, but I definitely understand why people use them to treat an undiagnosed condition. And that is one of the underappreciated parts of my job, one of the hardest parts of my job, is finding that diagnosis, because this patient population is classically underdiagnosed. They receive a low level of healthcare across the board. The third pillar would be pipelining into other treatment modalities. Classically, you have groups such as Smart Recovery or NA, 12-step groups, which are very good. Treating out someone to see a therapist or a clinical psychologist can be very beneficial. Making sure they get adequate social services, such as help with homelessness or domestic abuse, can be a key part of the job. And it's essentially what I tell all my patients when they come to my clinic is that the more you do, the higher your likelihood of success. Again, similar to diabetes, half will prescribe you just the meds if you want, but if you incorporate lifestyle changes on top of it too, you'll have a higher likelihood of success.
So in that way, we don't just assess and diagnose substance use and opioid use disorder the same way that we diagnose and assess other diseases. We also treat it like a disease. Is that right?
Correct. And it is a chronic medical condition with a lifelong diagnosis. And there is a big push in medicine for those of us that work in the addiction community in order to treat it as such, because that's what evidence shows works if you treat it like a chronic disease and not a moral failing.
So you mentioned moral failing,
Yeah.
and I think that's one of the big myths surrounding addiction medicine or addiction in general, not addiction medicine. But let's talk about some of those myths and specifically how addiction and substance use disorder is not a moral failing or a character flaw, but exactly as you said, it's a chronic medical condition.
Yeah, for sure. One I hear all the time is someone has to hit rock bottom before they get better. It's just simply not true. The earlier people get into my clinic and diagnosed, it's easier for both me and the patient to treat. I will treat anyone at any stage of their diagnosis, but I have patients that range from 2 months into opioid use to they have an infected heart valve and they need a heart valve replacement due to their substance use disorder. And I'll treat anybody, but it's easiest if you get in as soon as possible in order to treat. Another myth is that residential treatments is the gold standard for treatment. I purposely didn't put that on my list of treatment considerations because the evidence for residential treatment is very weak. I know we've all been told this watching movies and seeing TV shows and things like that. But right now, there are no standards for residential treatment programs. You don't need any training in addiction. You don't have to meet any federal standards. They're rarely run by physicians who are educated in substance use disorders. And the data is overwhelming that it's pretty weak evidence that you get any benefit from it. A lot of people like to think of it like a course of antibiotics. You just go to residential treatment for 30 days or 90 days and then you're cured. But lifelong diseases don't work like that. You need chronic treatment.
And you wouldn't go to a facility that didn't offer any professionally trained care for another medical condition. You know, I wouldn't go to an unlicensed facility to have a heart condition treated. Why would I go to an unlicensed or untrained person to have substance use disorder treated?
Yeah, that's exactly right. There is a lot of people think that treatment of withdrawals is the most important treatment for treatment of substance use disorder. Treatment of withdrawals is something I can do, and it's a very important part of my job, but we've studied this extensively, that simply treating someone from withdrawals or detoxing someone does not improve their chances of long-term sobriety. It's important, and it's something I'll happily do, but the hard part comes after treatment of withdrawals. I hear this one, and this is particularly hits hard for me, is that medication-assisted treatment is just swapping one addiction for another. It's just simply not true. We're going to get into this more from later slides on this talk, but it's something that we as a society should really just stop saying because there's no evidence for that, and it's just an urban legend, and it's not true. And that illicit drug use or legal consequences due to drug use is a key factor in diagnosing substance use disorder. It really has nothing to do with that. There are people that use illicit drugs that don't have substance use disorder. There's people that only take prescribed drugs that have substance use disorder. And it's not something that's part of my diagnostic evaluation.
Right.
Yeah.
So one of the things you mentioned there when we were talking about myths is the idea that using medication is just swapping one addiction for another. But I think in order to understand why that's not true, we kind of have to take a look at the science behind opioid use disorder and kind of what classifies it as actually a medical condition, as a disease. So let's dive in.
Yeah. So your D2 dopamine pathway is your pleasure pathway. And essentially this is what we evolved to feel euphoria, because initially we evolved to binge eat and have sex and explore. And all that releases euphoria in our brain. All substances that have the potential for addiction have the potential to downregulate the system, because when you first start taking the drug of choice, you have a massive dopamine response, but that decreases over time. And then you need higher and higher doses to get the same effect. And if you look at cocaine or meth or heroin or alcohol, they all have that same effect and they all downregulate that system. And that's what leads to addiction. It's important to note that nothing causes dopamine release in that part of your brain like opioids do. Nothing in lifestyle, no other drugs. Nothing's going to hit that receptor as hard as opioids will.
Can't eat enough chocolate cake to get that.
No, you can't. Yeah. Cravings. The way I like to describe cravings for people and the breakdown of your decision-making capacity is that imagine you were stuck in the desert for 3 days and you had no food or water and you were sweating and you were getting thirstier and thirstier. And then I came up to you to rescue you and I said, hey, I have this bottle of water, but I don't want you to drink it. And I want you to go to the hospital and I want to put IV fluids in you. And I told you if you took a sip of that water, you would lose your job, custody of your children, your house, your whole life would be in shambles. What would you do?
Probably take the water.
Probably drink the water, right? Our limbic system is our survival mechanism. And every brain has a breaking point where you lose decision-making capacity and it takes over. And that same pathway that would make you grab the water and that water would taste better than any other sip of water you've ever had in your entire life, that's the same pathway that leads to addiction to substances.
think this is a key distinction to make because I've heard you say that addiction lives outside of our consciousness to a certain degree, and this is essentially exactly what you're referring to. The limbic system is not something that we're aware of. It functions independent of our thought, and so if that's the center of the brain that's controlling addiction, it's something that does live outside of our control and our consciousness.
Correct. Yeah. So dysregulation of this dopamine system, there are a lot of factors, but there are three major factors when it comes to addiction. Genetics is probably the biggest factor that we know of. Certain people are genetically primed for certain types of substance use disorders, same as certain people are genetically primed for diabetes and hypertension due to too much salt intake. We know that chronic stress can affect this system, which is why people with chronic pain or PTSD or people who have adverse childhood events are much more likely to have substance use disorder, because those events and that chronic stress in the brain can actually activate some of those genetics in your brain and make you more likely to have a substance use disorder. And then we know chronic substance use itself actually downregulates that system, activates a lot of those genes, and it builds up the requirement to have further substance. And chronic opioid use increases your chances of developing an opioid use disorder.
And I think that really drives home what you mentioned earlier about you don't have to hit rock bottom to seek treatment or to get better. And in fact, when it comes to opioid use disorder, it's almost the sooner you seek treatment, the better.
It's true. Yeah.
Can we advance the slide?
So these are the two main sections of the brain I'm talking about when I talk about limbic system versus prefrontal cortex. And your prefrontal cortex evolved a lot later. This is what we treat with therapy and cognitive behavioral therapy and going to groups. Treating this is very important, and I'm a big fan of it for all diseases and for mindfulness and for self-control and for dieting, same as substance use disorder. But it's very important that we differentiate that the source of substance use disorder is in the limbic system. And that's a key part of treatment, and that's what a lot of physicians are trained to do, both for stabilization or for long-term treatment.
So again, we're talking about two separate parts of the brain, and they really have to be treated with two distinct but kind of coordinating treatment protocol.
Correct.
Right. Okay, perfect. So, this is something that I think is important because, we talk about treating with medication. So can you explain what's buprenorphine?
Sure.
And what's kind of the purpose?
Yeah. So buprenorphine is what we call a mixed opioid agonist-antagonist. And when we say opioid agonists, you have three major opioid receptors, and if you took a medication or a drug such as heroin or fentanyl or oxycodone, you would activate all three of those receptors and get a big flood of endorphins or dopamine in your brain. You contrast that with something like Narcan, which blocks all your opioid receptors, and when people take too much opiates, we block the receptors and it brings them back out of them. Buprenorphine, with your mu-opioid receptor, it partially binds to it and causes a small functional release of dopamine, but not enough to cause any euphoria, and then it blocks all of your other opioid receptors. So it's kind of a mix between heroin and Narcan depending on the receptor. It was developed in the 1960s as a non-addictive pain medication. It was much more commonly used in Europe than it was here for treatment of chronic pain. And we're going to get into why it's non-addictive later in this slide. But essentially, the short answer is that for a medication to have the potential for addiction, you're going to need higher and higher doses to get the same effect. Alcohol, methamphetamines, heroin, all fall in that. Buprenorphine doesn't have that quality. Whatever effect you're going to have from buprenorphine, you're going to have the same effect 10 years from now, which is why it's a safe medication for treatment of pain. It also, because it causes that dopamine release, is a very good drug to treat opioid withdrawal. And that was initially mainly what it was used for in the substance use disorder population, which came after the chronic pain population. And the big debate we had early on in the addiction community, particularly in the 80s and 90s, was should we just treat this for withdrawals or should we treat this long term? And we actually had physicians doing both at the time. And it was a debate in the community. In 2003, one of my favorite studies in the history of addiction was actually done in Sweden. And they took a group of people who used IV heroin every day, and they put them into two separate groups, and nobody knew who was in which group. And essentially what they said is, you are all going to get state-of-the-art treatment. You're going to get cognitive behavioral therapy, you're going to get group treatment, you're going to get regular visits with a physician, right? But the one key difference is we're going to start all of you on 16 milligrams of buprenorphine, so nobody goes into serious withdrawal. And in group A, we're going to taper you off steadily and then just give you a drug that's just a placebo, and you don't know if you're getting buprenorphine or not. And then in group B, we're just going to continue on 16 milligrams of buprenorphine daily. Patients were followed consistently. We got urine drug screens consistently. And then the question was there a significant difference? Because this was our big question back in the 1990s.
So just to decode that a little bit for those at home, essentially the goal of the study was to determine, is long-term buprenorphine therapy superior to just using buprenorphine as a detox mechanism?
Yeah,
right?
Who had better outcomes? Yeah.
So what were those outcomes?
Yeah, so if you look at the group who received buprenorphine for route and had their cravings well controlled, 75% of people had a 1-year retention rate, which is a slam dunk in opioid use disorder because it's very hard to treat. Mm-hmm. There are very few drugs across the board in medicine that have those kind of numbers. You know, we don't have hypertension or diabetes meds that have those kind of numbers where 75% of them get better. Right. Of the 75% of people that retained treatment on buprenorphine, 75% of those remain negative for all illicit drugs on every urine drug screens. 25% had some positives but stayed in, and that was for all drugs across the board, not just opiates, stimulants, THC, benzodiazepines.
So I think it's just to take it back to one thing that you said. I think it's really important to point out the efficacy of this treatment because, as you said, we don't even have that kind of success with hypertension drugs. And so essentially what you're saying is that this drug is a super effective way of treating opioid use disorder.
Yeah. And if you look at where it originates, again, the limbic system, that's where this drug works. You know, if somebody had low thyroid levels and was depressed and had weight gain, we could send them to a dietitian and a cognitive behavioral therapist all day long, and they would lose weight and they would improve their mood. But really, unless you got to this, it would be very hard to treat unless you got to the source of that thyroid and activated that thyroid a little bit to get that key level. And that's exactly what buprenorphine does in your brain. If we flip side it now to the placebo group, the people that just got treatment for withdrawal, and then, then just got a placebo for the rest of the year, can you guess how many people made it through, or what percentage of people made it through the end of the study?
I'm going to guess it would be really low, maybe 10%.
Yeah, it was 0.
Wow.
Not a single person completed the study. And this was one of the original studies, but if you compare 75% success rate to 0%, that's a big number. This was our initial study, and it's also, again, to reiterate, these people got state-of-the-art addiction medicine treatment for 2003 in Sweden, where they got regular group visits, cognitive behavioral therapy.
So they got it all, but what made the difference was the maintenance buprenorphine therapy.
Was stabilization of the limbic system. That was the most important part. So we repeated this study over and over and over again in medicine, and this is just one JAMA article I pulled up because it has a nice graph I like to use a lot. This was for prescription opioid pills, not for heroin, just to show the similarities, but they had a very similar setup experience, and what they showed is that people who stayed on buprenorphine as opposed to treating withdrawals had about a 70% success rate, whereas the people who tapered off had less than a 20% success rate. This was only over 14 weeks, but overall, each study with varying parameters gets about the same results. If you go on medication-assisted treatment, you have about a 70-80% chance of recovery. Without medication-assisted treatment, you have less than a 20% chance of recovery. Yeah.
So I want to pause for a minute and just take a couple questions from our audience at home. And the first question that we received is, are opiates and opioids the same?
Sort of. And I always mix these up, I apologize. Opioid, let's see if I could get this right. This was a board's question actually, but opiates, I believe, are classified both the natural and the synthetic, whereas opioids are only the naturally derived ones. And I might be mixing those up, and if I apologize if I do.
Right, so it's an important distinction to make, I guess, but I suppose for purposes of the larger conversation, not that important to really.
Yeah.
So does everyone who uses opioids develop opioid use disorder?
No, and that's a very good question. People who take a high enough dose of opioids for a long period of time will develop some level of dependence because your body's going to adapt and they'll need to taper off slowly, because if they suddenly discontinue, they'll have some element of withdrawal. We always think of withdrawal as shakes and tremors and sweating and diarrhea, and that's the classic withdrawal for heavy doses of opiates. But sometimes even for low doses of opiates, if you take them every day and we taper you off, you will get something called hyperalgesia, where your pain symptoms get worse. Things hurt more than they did before, even if you prick your finger, or you'll have a low mood or anxiety coming off of it because your brain's so adapted to that endorphin rush that it's going to come off. But not everyone who uses long-term opioids has an opioid use disorder. And in my clinic, we make that distinction a lot.
So if you're someone who has chronic pain or who's recommended to take an opioid as prescribed, what's important for that patient in terms of a conversation with the physician or in terms of setting themselves up for success in not developing an opioid use disorder as a result of taking prescribed opioids?
Yeah. I would say if you're working with a qualified physician or a pain specialist and they decide chronic opioid therapy is indicated, then you should do that. And we're going to run the risk for that, and you can always come see me if it starts to become an issue, and I'm happy to do that. I will caveat that to saying that the actual evidence-based medical indications for long-term opioid treatment for things like oxycodone and hydrocodone are very rare. We were kind of the only country in the world that decided to treat back pain and knee pain with those. And that can be a whole nother talk, and I'm happy to go into the data on that. But generally, when you stay on those meds long term, your pain actually worsens because you are burning out your opioid receptors. There's times we definitely do it. Classic case would be metastatic cancer pain, end of life pain. And there are some key times when we take the risk. The risk is worth the reward to give people quality of life.
So you're really talking about those palliative care and hospice care kind of situations.
Yeah, and there are some key chronic conditions that the only way you can have a quality of life and is to be on chronic opioid therapy, and that the only thing that type of pain responds to is opioids. But the majority of those pain syndromes, such as joint pain, knee pain, back pain, long nerve pain, the evidence that you get any benefit from opiates is very weak, and there's a lot of evidence it actually causes more harm than good. And that's a conversation we have to have a lot. But even if you are on it and you're dependent, that does not mean that you have an opioid use disorder. And I see both types of patients in my clinic, and yeah.
So shifting to more the recovery side of the conversation, how important are friends and family during the recovery process, and what does that involvement look like when you're treating or trying to recover from an opioid use disorder?
Yeah, that's a great question. This comes up a lot in my clinic, and what I always encourage friends and family to do, which is easier said than done, is be supportive and get them to a physician. Because oftentimes things are of the best intentions, but tempers and emotions run deep in addictions and opioid use disorders. And for me as a physician, I have no personal connection to it, so I'm very logical and pragmatic. I go down the diagnosis and the treatment options. And understandably, oftentimes, family members want to come to doctor's visits with me, and sometimes it turns into just a vent session for the family member because that's what they need. And I think it's important to vent, but that's not what the office visit is for with me. My obligation is to the patient and getting them the care they need. And if you are struggling with someone, a family member with substance use disorder, Al-Anon is an excellent group, and I would encourage you to get involved with them and be with people in the same boat and hear stories, because that can really make it a lot easier to go through to be in the same boat. But your role as a family member is to get them to a trained physician and encourage them to go get the treatment that they need from the physician.
Yeah. And I believe there's also, different types of treatment, that would be done in addition to the treatment that you provide that family members can participate in, and that would be kind of, affecting more of that cognitive part of the brain and that relationship part and codependency and some of those other factors. Yeah. So speaking of factors, are there certain factors that increase your risk for opioid use disorder? And if so, what are those factors?
Yeah. So we know anyone can develop opioid use disorder, but as we talked about before, genetics play a major role. And what we've learned is a lot of those genes that cause opioid use disorder remain dormant in your brain. It takes something to activate them. And what can activate them? History of trauma, history of sexual assault, Again, the adverse childhood event score, if you have a very stressful childhood, that can activate it. Chronic pain can be very stressful on the brain and activate those genes. And long-term opioid use can activate some of those receptors and put you at use for it. It is important to remember there is a push to assess for risk factors when prescribing opioids. It's a hot topic in the medical community. I can tell you the way I practice, opiates are indicated or they're not. And I would never say to somebody who had a broken arm or was coming out of surgery, well, you have a history of sexual assault and your parents were divorced, I'm not prescribing you opiates. No, right. Opiates are indicated. I'm going to watch it very closely in everybody. And if they're not indicated, I'm going to wean you off long term. It's important that we know the risk factors, but what I really hope medicine doesn't do is pick and choose. You are morally good enough to get opiates, we're going to give it to you. You're not, we're not give it. Mm-hmm. Short courses of opiates after a broken bone or a surgery is indicated. Long-term treatment of opiates, again, is very rare, but I've had patients with substance use disorder on palliative care because I don't care if you have a history of IV heroin use. If you have metastatic cancer, you're going to get opiates in my clinic. And that's how I answer.
So how long do you continue taking medications when being treated? So if you come to you, Dr. Kerrigan, for an opioid use disorder, if you are going to prescribe buprenorphine or any other medication that you would use, how long would a patient stay on that medication?
And I will say that's up to the patient and it's up to them. The data is pretty overwhelming that for naltrexone or buprenorphine or methadone, which is our three major treatments that we have for it, lifelong gives you the best chance of success. But if we do taper you off, buprenorphine or methadone works the same way. We know that the slower, the better. Slow tapers are much more likely to be successful than getting you off. It's a conversation I have a lot with my buprenorphine patients is that they want to come off or they want to try coming off. And I say, that's absolutely fine. Let's try it. Let's go slow. If your cravings become overwhelming or your mood can't function, we just go back up because I would rather have you be on buprenorphine than have that uncontrolled urge because then it's Russian roulette. You're going to get that one bad shot and then you're never going to wake up and then it's game over. I would say of the people that try and taper buprenorphine, I'd say about 30 to 40% successfully get off. Oftentimes those are patients that they had another disease that we treated. They had an underlying condition that I fixed. We stabilized with buprenorphine. We slowly tapered them off. Those tend to be the best. But really, that I will always leave up to the patient. You have to follow certain rules to be on buprenorphine because it's a controlled substance. But really, I tell you the pros and cons of both sides. Patients always drive the treatment in my clinic.
So you mentioned treating an underlying condition, and I think part of that speaks to the importance of diagnosis. And I think we're going to talk about the importance of diagnosis. But do you have an example, possibly, of what you mean by treating an underlying condition to help a patient who might be experiencing symptoms of opioid use disorder?
Oh, for sure. And again, there are very few things in medicine you can't get temporary relief from an opiate, a stimulant, or alcohol. I would say the one classically we see with opioids a lot is post-traumatic stress disorder. And oftentimes people with post-traumatic stress disorder have chronic pain. I've treated a number of veterans, I've treated a number of sexual assault victims. There's often physical injuries of how it starts. And after severe trauma, you will get a downregulation of that dopamine receptor pathway, and opiates will give you some temporary relief. I hear it from my trauma patients all the time. I was in a fog, I couldn't function, I took opiates, I just felt normal again. Because if you don't have that agonist property and you can enjoy a sunset and you can enjoy hugging your kids and you have trouble functioning, you'll get some temporary relief from that. Buprenorphine is a safe way to treat it along with all the other treatment modalities for PTSD. And in my clinic, we go 100%. The more you treat, the more likely you are to get better. That's kind of on the mental health side. A classic one for opiates on the medical side would actually, and this is something I didn't learn until fellowship, would be iron deficiency. I had a case once, a woman in her late 20s, she was having chronic restless leg syndrome and severe anxiety. And this had been going on for a while. It had been getting worse, and she was getting oxycodone from a friend of hers to treat it both. Iron is actually needed to make that dopamine, what we've been talking about, in the brain. And it's a very Goldilocks hormone. You don't want it to be high or low. And when it gets low, we always think of anemia and low blood counts with iron deficiency. But it's actually a pretty significant cause of both anxiety and restless leg syndrome, two different parts of the brain of that low levels of dopamine. The opiates will give you tremendous relief of both of those things if you have iron deficiency. People with severe iron deficiency do other, interesting things, like they eat ice chips and they crave dirt because their body's saying we need to fix this somehow. And that actually particular patient, she never developed a full-on dependence. We repleted her iron and she stopped using opioids. I didn't send her to cognitive behavioral therapy because it wasn't indicated. I didn't start her on medication-assisted treatment. I think she met mild use disorder criteria, if I recall. It was mild to moderate. Mm-hmm. I was ready to start MAT down the road if I needed to. But that's a particular case of why you need a physician to tease these things out,
right,
and have that full diagnosis to optimize your care. Same as I would never send someone to cognitive behavioral therapy because they're craving dirt. No, I would say we need to replete your iron. This is a commonly known thing. But someone who's not trained in it might say, you're eating dirt. That's off. I don't understand it. You need to go see a therapist.
Right.
And again, therapy is very important for the trauma patients. I push them into cognitive behavioral therapy because that's got the most evidence for it. Iron deficiency, I just fix.
Right. So along those lines, the importance of diagnosis. Let's talk about chronic pain, opioid dependence, and opioid use disorder, and how you diagnose and what that specific diagnosis means.
Yeah, for sure. These get lumped together a lot, and they're very different diagnoses, okay? Chronic pain is an underlying medical condition that leads to an overactivation of pain receptors, right? And it's going to be longer than 6 months. Sometimes even the underlying medical condition goes away, the initial injury goes away, but people still have chronic pain. There are many chronic pain syndromes, from small nerve pain to fibromyalgia to joint pain and swelling pain, and we differentiate the chronic pain syndromes into a lot of different categories because the treatments are actually very different for all the chronic pains. I work with a number of chronic pain specialists that are trained in this, and they mostly do procedures and use meds. They rarely use the opiates, the highly trained chronic pain specialists, but they do sometimes. Opioid dependence is from being on opioids daily and developing a physiological dependence. We develop physiological dependence to lots of medications. We develop it to antidepressants. We develop it to steroids and prednisone and things like that. And just being on it every day, your body will adapt. And if you are on doses long enough, you will have to titrate off, or else your body is going to go through some sort of mechanism of withdrawal. Again, that's very different than use disorder. There's a lot of overlap. And then opioid use disorder is a dysregulation of your limbic system. And this is where you lose your decision-making capacity, and that leads to compulsive use and social and health effects and worsening tolerance. And I have patients with all three of these. I've had patients that have only had one of those things. And yes, I think someone asked earlier, drug dependence can lead to opioid use disorder. You can break through and eventually develop one. But if you have drug dependence, I classify it as such, and then I talk about your treatment options for drug dependence, as I would for chronic pain.
And one of the things that I learned from you, as we were just talking earlier, is that it's not necessarily a continuum of progressing from chronic pain to tolerance to use disorder. They can exist all simultaneously. They can exist independently of one another, and they're very distinct diagnoses.
Yeah. I'll give you actually a great example. One of my favorite cases of all time was a hockey player from Boston when I was working at Boston Medical Center. Never did illicit drugs his whole life. He drank in high school a little bit, in college, but never had a problem. He played college hockey, and after one injury, he took oxycodone for his injury, and he said that was it. He felt like he was floating on a cloud, and that's all he thought about, and he started taking them. And he developed opioid use disorder before he developed dependence, and he never really had chronic pain. And there are people with the genotypes that when they take oxycodone, their brain is going to light up, and that's all that they're going to be able to think about after taking it. And if that happens, it's important to get into treatment as soon as possible. And it was interesting for me to understand, because I remember after my appendectomy, I got prescribed I don't know how many oxycodone, and I took them for a day and felt constipated, and I said, I don't want to be on this anymore.
Right.
And that doesn't make me a better person. That was just my genotype, and I have my own faults and my own things that I have to work on, same as he did. And again, it shows the diversity in this community. And any treatment program that says there is one treatment for this and you have to work our program because it's the best is just simply not true. And what continually surprises me about this field is how different every patient is and how you have to tailor it to that patient, because it's different for everybody how you treat it.
So with regard to drugs, there's a couple categories of dependence related to drugs. So let's talk about those, because I think it gives us a better understanding of the difference between just your basic antidepressant, for example, or even an anti-inflammatory versus opioids.
Yeah, it's true. So we don't often think about medications like this or drugs like this, but we should always classify all drugs into 3 categories. And there's drugs that can be started and stopped at any time without any side effects, right? You can be on antibiotics for 3 months and stop suddenly and just be just fine. You won't go through any withdrawal side effects. You can take acetaminophen for a month, that's like Tylenol or NSAIDs, and then you can just stop. There's drugs that need to be tapered up and tapered down, but don't cause worsening dependence over time. Example again of that, we talked about antidepressants such as Prozac and Effexor. Prednisone and steroids are like that. If you get a very bad allergic reaction, sometimes we put people on steroids for even up to a month or 2 at a time, and then we taper them off. And then you have buprenorphines in that category, because again, buprenorphine needs to be tapered up and tapered down. And if you stopped antidepressants suddenly, you'd go into withdrawal. If you stop prednisone suddenly, the withdrawals are actually so bad you could die. Your blood pressure goes down, you don't have enough salt to maintain things, and you go into adrenal crisis. But we don't consider prednisone addictive. It doesn't cause that response in your limbic system that needs bigger and bigger dose to get the same effect. It's a drug that it has to be prescribed very carefully. It's not an addictive drug. And buprenorphine is in that same category. So when I talked earlier about people say, if you're on buprenorphine, you're swapping one addiction for another, it's just not true. It's a lie. And again, we need to stop saying it. There is no such thing as buprenorphine use disorder. We've really tried to find that. Even that one patient with that rare genotype that needed bigger and bigger doses of buprenorphine in order to get the same effect, and it interfered with their life and they do anything to get it. No. You'll withdraw from buprenorphine if you stop suddenly, but it's non-addictive. Now, we'll come back to the third category, and that's medications that cause worsening dependence over time, requiring continually escalating doses to achieve the same effect. And any med or drug that can cause that has the potential for addiction. It's oxycodone, hydrocodone, fentanyl, most of the other opiates are like that. Alcohol, benzodiazepines, cocaine, methamphetamines, etc. And sometimes we use some of these drugs in medicine, and sometimes we even use them chronically. But again, that's it's rare conditions, and it's when we've calculated the pros and cons of when it's okay to use this, and when we said, hey, this is what we got to do, but we treat it with a high level of respect when we use these drugs long term.
So, as we've gone through this conversation, we've talked a lot about, the use of buprenorphine, and we've also, used the analogy of hypertension, and we've touched on diabetes as another analogy for how you should treat opioid use disorder, as a disease. We don't hesitate to prescribe hypertension medication. We don't hesitate to prescribe insulin to a diabetic. And it seems to me that these drugs that we don't hesitate to prescribe treat a disease in the same way that buprenorphine does. So why is there a hesitancy, and why is there such pushback when we talk about using this drug to treat opioid use disorder?
Yeah, I'd say again 2 major reasons. There's major stigma in society against this, and it's yet to be a standard part of the curriculum for most training programs. I don't care what you studied in residencies, obstetrics, surgery, psychiatry, whatever, you know how to treat hypertension. We all know how to do that. If you compare opioid use disorder to hypertension, and I treat both every day in my clinic, the best treatments for hypertension, hands down with the most evidence, would be weight loss would probably be number 1, quitting smoking would probably be number 2, and low salt diet would probably be number 3. And then we can start with the medications. But there's no medication that I've seen has higher evidence of efficacy for hypertension than lifestyle changes. But I can't imagine a scenario where I would say, I'm going to do weekly drug screens for nicotine, or you're not getting your hypertension med. I would never do that to a patient. I always explain this to the patient. I say, your best chance of getting better is lifestyle changes. Even if a patient declined that, have no hesitancy to prescribe hypertension medications, and nobody in society judges people for being on hypertension meds. Nobody ever says, why don't you just stop eating salt? Because that's what our medications do. Most hypertension meds, not all, they just get you to pee out more salt, and it lowers your blood pressure. And people are applauded and encouraged to be on hypertension meds because it keeps them out of the hospital and they live longer. But what my patients have to go through to be on this medication, the stories I hear, it's unreal. Some keep it a secret from their family. Most won't tell their employers because they know the stigma associated with it. Some of them are on probation and have to keep it a secret from the judicial system because they live in sober living houses that don't allow them to be on medication-assisted treatment, and they have to hide it. And it's really too bad because if you compare it to substance use disorder, your best chance of success for opioid use disorder, not other substance use disorders are a little different, your best shot of success is being on medication-assisted treatment. So if we were going to have, logically focus lifestyles one on more than the other, we'd focus way more on hypertension than opioid use disorder, because the data is better for the lifestyle changes for hypertension, but it's not for opioid use disorder. And it's really too bad, the level of stigma these patients go through. I don't know how they do it.
Right.
Anyone who comes to my clinic knows I make the time for them because I know what they had to go through to get to my clinic and the amount that they had to suffer in order to even see me. Yeah.
Right. And I think, we chatted earlier about how, residential treatment facilities are not the gold standard for opioid use disorder. And I think one of the things that you just mentioned that we should kind of wind back to and emphasize is that a lot of these residential treatment facilities will kick you out if you are on medicine-assisted therapy. So if you're taking buprenorphine for opioid use disorder and they find out, they'll actually kick you out of that sober living facility or the group home environment. And it just doesn't make sense. And that, I think, again, just to emphasize the point that you really do need a medical professional to treat this condition. And that's why it's so important that we're having this conversation to to bring awareness to kind of these myths and to the misconceptions about how this is best treated.
Yeah. I can tell you all the addiction medicine physicians in town, and I think I know all of them, there's not a lot of us, are all disheartened in Ventura County that more programs don't want to work with us. Because when you combine medication-assisted treatment with treating your social situation, getting a place to live, sober living, with an intensive outpatient program with therapy, that's your best shot of success. The more things you do, the more likely you are to be successful. But I have gotten phone calls from outside programs and therapists to my office demanding that I take people off buprenorphine. I of course say no, because if you wanted to make medical judgments, you should go to medical school, and I'm not going to tolerate that. But it's just sad that we live in a community where that's going on. I think one of the most heartbreaking ones is, my patients on probation because of their disease, and they have to live in a sober living as part of their probationary period, but their sober living doesn't allow them to be on buprenorphine. So I know I have the gold standard, which is medication-assisted treatment. I want them to be on it. And they have to make a choice of taking a medication that's the gold standard for their disease that's recommended by a physician, or being incarcerated. And I don't know how we got to that, but I know that it's wrong. And that's not the system that we should be in right now.
It's definitely a much larger conversation, unfortunately, than what we have for tonight. Yeah. But I hope that at some point we get the chance to dive into it a little bit further, because I do think it's important to explore those kind of dichotomies in our society and in medicine. Yeah. Getting back to treating and how you treat, tell us about your clinical practice and how you treat opioid use disorder and kind of what does success look like?
Yeah. So I'm a general internist first. I got subspecialty training in addiction medicine, but I treat a lot of chronic conditions. And my goal with all my patients is the same. I want you healthy and happy into your 70s and 80s. And that's a lot of preventive medicine, and sometimes that involves lifestyle changes, and sometimes that involves long-term medications, but it's right for you. If you come to my clinic, no patient gets treated better than the other. I have patients with substance use disorder, I have patients with chronic pain, I have patients with none of those things. I'm going to treat you to the maximum of my ability. It's important to note that I'm not going to prescribe an addictive medication that I don't think is indicated, so I very rarely prescribe long-term opiates or benzodiazepine because I think the evidence is not there. But again, buprenorphine treats chronic pain. That's what it was used for. And I have a number of patients only on buprenorphine for chronic pain, or they had some element of opioid dependence in chronic pain. And I document it as such. And everyone, I make the diagnosis based on the criteria, and everyone gets treated to the max of my ability. That's what you get in my clinic.
So what does success look like in addiction medicine?
Yeah. So success is long-term recovery and then being happy and healthy into your 70s and 80s. That's what I would and most of my patients, once they get to about a year or two, they have to see me, but it's a lot less work, both for them and for me. And of course, I will always jump in and intervene when I need to. But usually with my patients with substance use disorder, and this is what I always tell them, is that if we front load the work now and we figure all this stuff out, then we're going to get 30, 40 years of success and happiness. Because my patients on buprenorphine, I see them every month because that's the federal regulations. But the ones that are years out, it's usually a more of a high and by conversation.
Right.
Touches on another thing I actually recently started here at CMH. I'm a big fan of the buprenorphine group model. So patients of mine who have substance use disorder that are on buprenorphine are welcome to come to groups and get refills. It's run just as a support group, all people on buprenorphine, often stories of stigma and the things they had to go through from everybody to be on this med and getting better, both before they got better and after they got better. It's completely patient choice. I'll see you one-on-one too. But I'm a firm believer of that group model. It's very common on the East Coast, less common out here on the West Coast, but I'm trying to get it going out here.
So where does that group take place and how does one attend, or is it just show up, and where do you offer it?
Yeah, so if you want to start attending these groups, they're at the Midtown Medical Group. I run them on Wednesday nights. All you have to do is make an appointment with me and establish with me, and we'll talk about buprenorphine, and I can either get you started or continue what you're on. And then if it sounds like something you're interested in, I do it after hours so people with 9 to 5 can come after work. And it starts at 5:45. And you just book an appointment with me, and we can talk about getting you in.
Awesome. It's a great and wonderful service to provide to the community and to our patients. I want to get into a few more questions from our audience. And just to start off with, how does your program and your treatment handle relapse, and what does that look like?
Yeah. So if somebody were achieving for sobriety and they use substances again, there's always a higher level of care. So whatever we were doing before, I have patients that come in and say, I don't want to do medication-assisted treatment. I just want to do NA groups, and I want to treat my anxiety. I say, okay, let's do that. If that works, we're done. If that doesn't work, we're going to talk about switching things up or adding something else. Some patients just want to do medication-assisted treatment and not do any other thing. Of course, that's as your call. And what I do is I picture it like hypertension or diabetes. If I had you on whatever our plan was for hypertension, and suddenly you came in and your blood pressure was high consistently, I would say, okay, we need to make a new plan. And I've had patients that are sober for 6 months or a year and then they're not anymore. I always, again, encourage you, the sooner you come in, the easier it is to treat rather than disappearing for 6 months or a year. And then we talk about treatment options, and the patient always drives the plan. I say, these are our options. These are options for a higher level of care. What do you want to do? And in my clinic, when you're treating substance use disorders, all my patients know that what your plan A is less important than your plan B is you come see me. Because again, I can always escalate care. I can always look for new diagnoses. We can always try something else.
Right. So again, just back to the same way you would treat any other medical disease, medical condition.
Yeah.
You treat, you evaluate, you assess, reassess, and continue to treat.
And to the extreme, I've had patients that they say, I really like using heroin and I don't want to stop right now. I'll still be your doctor. I'll give you insulin, I'll treat your hypertension, I'll get you onto birth control, I'll get you Narcan kits in case you overdose. And if you're regularly using, there's no stigma in my clinic. You come in and you see me and we chat it out. And then when you're ready, I will get you there. And I've had a number of patients that establish with me, use for a few months, and then one day come in and say, I'm ready, let's do this, and I'm fine. And it is my duty as a physician to keep them safe and also keep the community safe. Help prevent the spread of disease and talk about sterile needle technique and not passing on HIV and hepatitis C and other diseases to people. and helping people avoid unplanned pregnancies. Because if you don't want to have a pregnancy because you're actually using, I'll work to make that happen. And if all physicians, I believe, did that, I believe we would solve a lot of problems in society just by making people feel able. You should just be able to walk in, even if you're using heroin every day, and see your doctor. Right. We all have a right to health care.
How does one make an appointment with you?
If you just look online, I work at 3 clinics. 2 through the Centers for Family Health and 1 at Midtown Medical Group. If you call the number there, I take most insurances in town, and then I do take cash patients also if you don't have insurance. But I'm pretty much covered by everybody in Ventura County now, I think, almost all the insurances. You call my front desk and you say, I want to make an established appointment, and then we sit down and we chat it out.
Can you give us a percentage of people who've been on Suboxone for years and have successfully weaned off? What does that look like?
Again, I haven't found clear data of people that have successfully weaned off. So I always like to start with, if there's big studies have been done and evidence shows they can do well. Those studies aren't out yet, so I don't want to say the science. I can tell you from personal experience of the patients that say, I want to wean off, I would say about 30 to 40% make it. And I've had patients that wean off and do great. I've had patients that wean off and switch to naltrexone or Vivitrol, which is, we didn't get into tonight, but is another drug that has no level of dependence that can help with opioid cravings. I've had patients wean off and a couple months later say, I just can't function. I want to be on low dose Suboxone. And I've had patients that get to a lower dose and just say, nope, I just want to live my life. And I wake up, I take my buprenorphine, my day's my day, I go to work, I raise my family, and I'm just going to stay on it forever. And what I encourage people, I'm always happy to try. We should go slow. If it doesn't work, that's your brain chemistry. It's not a moral failing. Some people are going to get off. I don't want you to be on a med if you don't need to be, so I'm happy to try. But don't beat yourself up, and I hope people don't judge you for not being able to come off of it. It's okay.
It's not a character flaw.
Yeah. Nope. Yeah.
So, we've talked a lot about opioid use disorder specifically, and how we work to treat that, but can all types of addiction be treated with addiction medicine?
Yes, all can. I can say that right now the best medications we have for cravings are in the opioid class. We're very good at treating cravings, and that we have very high success rates with the medications. But I can treat alcohol cravings, I can treat methamphetamine cravings and cocaine cravings and THC cravings. I sometimes see gambling addiction and sex addiction too. And then, as always, oftentimes with other types of addictions, that second pillar of finding the underlying diagnosis and pipelining into other treatments can be very important, because there are very certain medical conditions that alcohol will provide temporary relief for, and there are certain medical conditions methamphetamines will provide relief for. And digging down and getting that diagnosis can help people in their recovery.
Right. So again, it's all about diagnosis.
Oh.
Yeah. Well, other forms, I'm sorry, just waiting for the question to pop up.
Yeah.
Well, other forms of treatment typically continue even after medication has ended. So if you have a patient who has been on buprenorphine and is able to wean off, do you recommend that they continue other forms of treatment? Should they continue to see you? Do they continue to do cognitive behavioral therapy if that's been part of their treatment?
Yeah. Of course, it's a lifelong diagnosis. Some of my patients, I'm their primary care physician, some I'm just a consult, but I'll be your doctor forever. So you come off buprenorphine, you don't have to see me every month like you do when you're on buprenorphine, but you keep seeing me with concerns, and I'm happy to treat it. And I've had a number of patients that continue to do group therapy in Narcotics Anonymous, and I always encourage that. Ultimately, again, it's up to the patient, and if they wean off and say, I'm good, I know I'm fine, I'm done, I say, okay, but my door's always open, so if that changes, you come see me. But definitely encourage all other treatments on top of it, even if you come off buprenorphine.
Is there anything else that you would want prospective patients to know about you or about your practice?
Two major things. I treat everything, and everyone gets treated the same in my clinic. It's important to note, again, I will help you come off of addictive medications, but if I can't find an indication for it, I'm not going to prescribe it. So there's a lot of people on, opiates for their knee pain. I can switch you to bupe or I can get you off of it, but if I don't think it's indicated, we can talk about getting to a pain specialist, but I'm probably going to take you off of it or transition to bupe. And my final one, and I say this to my patients, the amount of stigma and the amount of barriers, so many patients with substance use disorder had to go through to get treatment. I spent a lot of time begging people to stop eating sugar and begging people to stop eating salt or just take their medications for their cholesterol, their blood pressure, and a lot of them didn't, and nobody bats an eye at that at all. If you make it into my clinic with substance use disorder, I know what you had to go through to get there, and I got all the time in the world for that. I'll treat my diabetes and hypertension too, but you come see me and I will listen to you and we will hash a plan out together.
Thanks, Dr. Kerrigan. I think we've really just scratched the surface on this topic, and there's so much more that we could dive into and really take a look at. But I'm hoping that we'll be able to continue this conversation again in a later installment of our speaker series. But we want to invite our audience to be sure to engage with us, share your questions and your comments about this live event on our social media channels. Be sure to follow us on YouTube at Community Memorial Health System and subscribe to our email list for the link to the recording of this event, as well as updates on events to come. Again, Dr. Chris Kerrigan practices at Midtown Medical Group here in Ventura, as well as the Community Memorial Health System Centers for Family Health. You can find out more about Dr. Kerrigan and all of our physicians at cmhshealth.org. Thank you so much for joining us this evening, and good night.